Hello and welcome to another episode of Feminine Scope, a program where we discuss issues affecting women, celebrating their triumphs and seeking ways to solve their challenges. I am Amanda Ezekwe. When some of the body cells grow uncontrollably and spread to other parts of the body, it is called cancer. Cancer can start almost anywhere in the human body, which is made up of trillions of cells. Normally, human cells grow and multiply to form new cells as the body needs them. When cells grow old or become damaged, they die and new cells take their place. As Nigeria joins the rest of the world to mark the World Cancer Day, a research by the World Health Organization has said that Africa records around 1.1 million new cases of cancer, resulting in up to 700,000 deaths every year. How can we create awareness? Are there preventive measures? Is cancer a death sentence? These will be our focus on Feminine Scope. My guest for today is a consultant, radiation, and clinical oncologist. You will get to meet my guests after the break. Stay tuned. Welcome back. If you're just joining us, this is Feminine Scope, and today we'll be discussing cancer in women. And my guest is the former head of Department of Radiation and Clinical Oncology, National Hospital, Abuja, a visiting consultant, radiation and clinical oncologist, Federal Medical Center, Jabi. He's also a senior lecturer, University of Abuja, College of Medicine, a member International Cancer Expert Corps, ICEC. He's the Chief Executive Officer and founder, Pathfinder Healthcare Foundation, an NGO, Dr. Chinedu Aruah. You're welcome, sir.
Thank you, Amanda, for having me here.
It's a privilege to have you on my set. You're the first man who will be sitting here to talk about women-based issues. So, celebrating the Cancer Awareness Month, which is this month, we would like you to talk about cancer. What exactly is cancer? Because we hear cancer, cancer, cancer. What exactly is cancer? How can you explain to people in a very simple language?
Okay, thank you for that question. I'll put cancer in, explain cancer, define cancer in this form. A cancer is a group of cells that grow continuously. They are purposeless, are useless to the body, and may cause malfunction of the body if not well treated on time. So cancer as a disease knows no sex, no age limit. It can affect a child in the womb, a baby in the womb. It can affect an adult. It can affect a woman. It can affect a man. It can affect any age group. So in that case, it is a disease that's not selective, and the more people are aware of that, the better in terms of health-seeking behavior, in terms of getting a better outcome in early treatment and detection.
What are the types of cancer we have? Because we hear a lot. So what are the types of cancer we have?
There are many. They are in thousands, because every part of the body is susceptible to cancer. So you may have cancer that's occur in the eye, the breast, the nose, everywhere. So naming them is just like going into an ocean and trying to deep hand.
Okay, let's narrow it down to...
So, but we can talk about the most common cancers in Nigeria or worldwide.
Okay.
So,
let's narrow it down to the women.
Okay. Okay, if you narrow it down to women, we now talk about the breast cancer, even globally, is the most common cancer all over the world. And it has overtaken what we call lung cancer, which originally was the most commonest. And in terms of mortality, it's the fourth most common cause of death among cancers because of increasing awareness and increasing survival. And also the increased or improved in technology as far as detection and technical expertise is concerned. So apart from that, we have the cervical cancer, which I will say that is a disease of environment, where a woman finds herself, the access to health, the level of education, and ability to have that cancer awareness information. So it's a disease that actually in a good setting, that have a good health facility, it can be eradicated. Like what the World Health is doing now, there's a strategy we call 90, 70, 90. 90 is about, we are talking about having 90% of girls less than 15 years being completely screened. And then 70 is having women that are affected by cancer, treating about that of the initial one is the vaccination. Then treating about those who are 35 to 45 years of age that have cancer. Then the other 90 is about making sure that 90% of those who are affected are already treated. So this is part of strategy is mapped out that by 2030 we will have a complete reduction or complete eradication of this disease. So it's a disease that is amenable to treatment and early detection and vaccination. So apart from that, we have another one which is called colorectal cancer, which is a disease affecting the large intestine, the rectum, and the big bowel, or the large bowel. That is another one. Then we have the one that we call the liver cancers, and apart from that is a disease that is mostly related to infection. Most of the causative agent is the what we call the hepatitis B surface antigen infection and virus, hepatitis B virus infection and hepatitis C virus infection. Then it's a disease that through vaccination and early detection is equally possible to eliminate it. Also, alcohol, large consumption of alcohol is attributable to it, as well as people who abuse drugs.
Okay, we'll actually come to that.
Yes,
but we want to, these are like the causes of, of it.
Then we have another one we call non-Hodgkin's lymphoma. So these are the 5 most common cancers in women.
Okay, let's start with breast cancer. What is actually the cause of breast cancer?
Well, the cause of breast cancer, most often, the cause of breast cancer is unknown. Let me put it, 80% of cause of breast cancer is unknown. But the other ones, when you say that it's unknown, it means that it's sporadic. It can just suddenly occur in a patient that doesn't have any risk factor. But in the other 10 to 15%, it occurs in a case whereby we talk of hereditary or a genetic risk. So whereby a patient that has some gene abnormalities is highly susceptible of developing breast cancer. And in that case, we must do a kind of gene profiling that say actually that this is genetically related.
What of the cervical cancer?
Cervical cancer is more of an infection by human papillomavirus, which has different subtypes or serotypes.
Okay. Can cancer be treated?
It can be treated, and it's treatable. The only challenge,
especially for the breast cancer, because that is actually the most common, but we feel cervical cancer is the most deadly. You in the medical circle who understands this more, you've treated thousands of patients.
Yes.
In your course of, career. Which one would you say is the deadlier?
Well, I would say that breast cancer is deadlier because of most often in our environment, patients do not present early enough. And is most common cause of mortality among cancers in female. So we'll say that breast cancer is most deadlier and most common cause of mortality, that's death among cancers in female. And the reason is that because of late presentation. And in overall, what determines whether a patient is likely to survive breast cancer or not is what we call the stage of the disease. The stage is now trying to tell you the likely outcome of the disease when the patient comes to the hospital. Like we have stage 1 to 4, The patient presenting at stage 1 have a better outcome compared to patients who is presenting at stage 2 or stage 3 and stage 4. So the earlier the patient presents to the hospital, the higher the chances of being cured. So in terms of curability, a lot of patients are surviving breast cancer, not only because there's newer machines, newer technologies for handling the case, but now patients are being increasingly aware of the disease through going for breast screening tests, breast self-examination, and equally going for clinical examination and biopsy. So with those things, you can see that patients were able to get through in terms of curability.
Okay, knowing that breast cancer is the deadlier one now from
Yes.
the medical angle,
yes.
How can we prevent it?
Well, for the one that is hereditary, it's not preventable. But you can do what we call or what we call risk-modifying behavior.
But how can you know if it is hereditary?
Well, we normally do a test. And most often, is a patient presenting to you and telling you, maybe a young woman telling you that the mother had breast cancer and the younger sister had breast cancer, or one of the closest relative died of breast cancer. So in that case, you must do a test to screen the family and to know whether there's whether the case is gene-related or not.
Okay. So do we contact cancer from what we eat?
Yeah, sometimes it may not directly be contacted in that form, but it may predispose. It increases the risk of developing the cancer.
In terms of what we eat?
Yes.
Foods like?
Yes, we talk about food
soft
that...
drinks?
No, some drinks that are going to, like alcohol, increase consumption of alcohol, then food that increases this body size, what we call obesity. So this obesity will now going to predispose a patient to developing cancer. So, but directly, you cannot say that because of the food he has eaten, that's causing it, but the food now triggers the risk of developing the cancer.
This one is generally for?
Everybody.
Everybody?
Yes, for almost all the cancers.
Okay. Naturally, can we treat cancer?
Yes. There are so many ways of treating cancer. And the best way of treating cancer is, first of all, when the patient presents, not all growth in the breast is cancer. So that's one of the things we must distinguish. Not all growth in the breast is cancer, because there are some cases that we have what we call benign lesion, or a baby that, or a young girl that's 16 years and have a small lump. You may find out it's just a benign growth, what we call a fibroadenoma. But sometimes cancer can occur in that age group. We have had cases whereby somebody that's 16 years, a girl that's 16 years, had a breast cancer. So, but what you're going to do is that, first of all, when the patient presents, they have to take a sample from the breast. And it's when they take the sample from the breast, especially for those that are present with a lump, that you can actually take the sample to the lab, which called the pathologist lab. When you get to the pathology lab, the pathologist will examine it under a microscope and come out. They already have a baseline of normal tissue and the one that's cancerous. So they will look at it. If they have some cancer cells, they will tell you that this is cancerous. And from there, the patient will be referred back to us. I will now look at whether the patient will be in position to receive surgery or chemotherapy or radiotherapy and the rest of other hormonal treatments. So the histology is one of the key factors on determining whether a patient has cancer or not.
Women always, come to the hospital to check, not regularly. What advice would you give to women? Because they don't come, when they even come to the hospital, for the fact that they are even told to do a test or check, they feel it is already a death sentence.
Yes, cancer is not a death sentence. Having cancer or having any swelling in the breast is not a death sentence until you must have done the test and it's proven that it's cancer. And with those stages, early detection, once you have early detection, the curability is high because with surgery, they can remove it entirely and you don't have need for further treatment. With surgery, they can remove it and say, okay, in this case, we can go further and do what we call radiotherapy using a kind of a light, but high energy light to burn that area that was excised. Or they can introduce what we call chemotherapy, either to shrink the tumor and make it easy to operate. So those are the things that we do. Sometimes there may be a case whereby we just excise the tumor, remove it, and place the patient on hormonal therapy, which is a drug that's going to suppress the further growth of the cancer or patient developing cancer from the other breast. So when the patient presents in the hospital, they should not they should be able to have what we call holistic check. What we call holistic check is that when a woman have opportunity of coming to the hospital, they should be able to undergo either breast ultrasound or mammogram, depending on age. For those who are mammogram, for those who are above 35 years of age, they can easily have mammogram, depending on the density or of the breast. Then for those who are less than that, we can have a breast ultrasound, which is equally sensitive now. And we have equally what we call breast MRI. You can do breast MRI, and that is equally a highly sensitive way of checking for breast lump or checking for any changes in the breast. And it's not every changes in the breast that is cancerous. There are certain key things we see, and we say this is suggestive of cancer, even before we do biopsy. And when we see that, we make sure that we ask the patient to go for further evaluation. And that further evaluation is taking a sample from the breast.
Okay, a woman comes into the hospital, does her check, something is suspected, and she goes for a histology, and it is confirmed that it's cancerous.
Yes.
What is the step or the stages she has to undergo? You mentioned some of it, but I want you to run through that stage.
Okay.
Because, first of all, when the person is told, shock, disbelief, then grief,
okay,
because they assume it's a death sentence.
Okay.
So run us through the stages of how they can go through
Once the patient comes to us, what we do is that, first of all, we have to allay your fears to tell you that it's not a death sentence. We will even point to you those who have survived before, and those who are on treatment, and those who have been on their checkup, post-treatment, 5 years, 10 years, post-treatment. So, and normally, a patient who coming to the hospital first time, we take what we call medical history. So medical history is that we now try to ask some questions surrounding the patient to know whether the patient has a risk factor of developing that breast cancer, whether it was just a spontaneous case, or what we call sporadic case, or whether there's genetic link. Is there any of the relatives that had cancer in the past? Is there any case of a lesion in the breast before? Then does the patient smoke? Does he drink? Does she breastfeed? Has she had a baby before? Is she married or not? So those are we start looking at so many risk factors that may predispose the patient. So that medical history will equally tell us other comorbidities, because a patient may be presenting with breast cancer, he may have hypertension, he may have diabetes. So in that case, you must equally carry those treatment along. You must invite the respective specialist in that. Maybe those handling diabetes, which we call endocrinologists, he must be there. Those handling case of hypertension, we call cardiologists, they must be there. So that the treatment must be holistic. And in management of cancer, we have what we call multidisciplinary treatment. So every sector or every specialist contribute to make sure that they treat the patient. So after the medical history, then we're going to give the patient some baseline this test to do. Then that baseline examination is to look at other factors, other things that may contribute in helping us to know the stage of the disease. So when we must have gotten the stage of the disease, that stage of disease is going to now define the actual treatment the patient will receive. Is this patient a patient we are going to refer straight to the surgeons? That, like those who have stage 1 or what we call carcinoma in situ, the cancer is still at very, 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 very low level. We may not go ahead to do other big things we normally do. So we just refer the patient to the surgeons, and they remove the lump quietly, and there will be no problem. And in that case, there may be no further treatment apart from the surgery. Then there may be a case whereby we will now look at, from the test we have done, that the stage means that we have to shrink the tumor before the surgeons do the operation. Then we are now going to use what we call chemotherapy to shrink the disease and make sure the breast is now, or the tumor is operable. So from there, we send the patient to the surgeons. The surgeons will operate and send the patient back to us. We now do radiotherapy. After the radiotherapy, depending on there's what we call immunohistochemistry. Depending on the hormone status of the patient, we'll know whether the patient is a candidate we are going to continue with the hormone therapy, or the patient is a candidate we are going to continue with some targeted therapy, like the one we call trastuzumab or Herceptin. Then we know whether the patient is the one that, at that point, the treatment has ended and is now on follow-up. Then it is equally helpful us to know whether the disease have gone to the extent that the patient is we're no longer talking of curability, we are talking about palliative, whereby the patient will now have to receive, apart from the treatment we are going to, patient subsequently will be receiving what we call supportive care. Patient will come in, we treat this one. In that case, we are no longer talking about cure. We are now talking about giving the patient a very good quality of life, because we know that the disease have moved away from the breast to other part of the body. Sometimes it moved to the lungs, sometimes it moved to the bone. And this happens especially for those who present very late. So the stage the patient presents is very critical to curability of every cancer. So the earlier the patient presents, the better the outcome. So we now talk about what we call health-seeking behavior, because health-seeking behavior is the ability of the patient to report to the hospital once he's suspecting something abnormal in the system. So most of the patients that present, most of the females that present to us very late is because they never, or either they are delayed in terms of their diagnosis where they are, or they never knew that what was happening to them was cancer in evolution. So they didn't report early enough. So by the time they are reporting, there's already a wound on the breast, the nipple have been chopped off by the cancer, or there's already a fungating lesion all around the breast, or the armpit is already swollen because of the lymph node that's in the armpit that always enlarged if there's a cancer in the breast, especially for advanced cases. But for those that is early, we don't feel anything in the armpit. So majority of the cases that people talking about patients dying of cancer not being cured is because of their presentation.
So early detection is key.
Is the key.
Now, while you were mentioning the stages, you mentioned chemotherapy and radiation. What is the difference between these two?
Okay, chemotherapy is the using of chemical agents, or let me call it drugs, to treat cancer. And the basic aim is to shrink the cancer and make it operable. And at times, for few cancers, it can completely eradicate the cancer. There are some cancers that chemotherapy can completely eradicate.
Okay.
Yes.
Then for radiation?
Radiation is you are now trying to make sure that the cancer that after operation, that the cancer cells within the region of excision or surgery is completely eradicated, so that if there's anyone on the surface or anywhere, that the radiation will burn it off.
So what are the after effects of the cancer treatment?
It depends on the modality that we are talking about. Is it surgery? The surgery has its own complications. Is it chemotherapy? It has its own complication. Is it radiotherapy? It has its own complication. Is it hormonal treatment? It has its own complication. But each of them, we normally look at whether the complications or the adverse effect whether the benefit outweighs the adverse effect. Once it outweighs it, we are not worried about that, because most often the complications are transient and is easily amenable to management.
Okay, so what are the diets a cancer patient should take? Okay, let's start before the person is diagnosed of cancer. What are the diets women are supposed to be taking to prevent cancer?
Generally, the food we eat are okay. Anything you take in moderation is okay. Because the only thing we will advise is that we advise for a balanced diet and what we call risk-modifying behavior or lifestyle modification. If you are taking a balanced diet and you're exercising and we are able to avoid obesity, then the risk of developing breast cancer is way, way down. So as long as a patient is taking a balanced diet, the body is able to take what it wants and remove what it doesn't want. It is now when you now start taking something in excess that you start having problem. But in general, most of the fatty food is a triggering factor. So there should be emphasis on taking less fatty food and more of vegetables and fruits. So if you add them in the diet, it helps in mopping up some what we call free radicals that are a triggering agent for this cancer.
So we've talked about before cancer. After cancer, what kind of diet should the patient take?
The same balanced diet.
The same balanced diet?
Nothing. Fruits.
Some people tell us that when you take so much sugar, when you take so much carbohydrates.
That's one of the things we have been talking about for quite some time. And the people normally come to this clinic to tell us, doctor, they have asked us not to take anything sugary, anything sugar at all. But that is not true. We are going to go into what we call the way the body synthesizes glucose. Because every carbohydrate we take ends up with glucose, and that glucose is what gives us energy. And even when we are starving, the body must convert any food substance in your body to glucose. Without glucose, you won't have any single energy to exercise, to walk around. So what happens is that people should not be talking about not taking anything that contains sugar, because every food, if you take protein, if you take fat, if you are starving, the body will go through a process what we call gluconeogenesis, whereby the body synthesizes glucose through other substrates that's not glucose. So it must convert, but it's now energy consuming. So the body doesn't like to go through that pathway. Because it involves tissue breakdown. Tissue breakdown. You just imagine someone have not eaten for 3 days because he's not taking carbohydrates or he's fasting. The body is going to recruit the fats in the body to pass through a process that's going to generate glucose. If it is protein in the body, it's going to convert the protein to pass through a process that's going to produce glucose. So, in other words, glucose is a must in the body. So anybody telling a patient not to take anything, carbohydrates and the rest of them, is punishing the patient, because the body must need glucose. So we have already lectured a lot of patients to tell them that they must take every food they like, they want, but in moderation, and it must be a balanced diet. And a balanced diet is known that it must contain the fat, it must contain the protein, it must contain the carbohydrate, then it must contain the essential vitamins.
Okay, let's move a bit to symptoms. What are the symptoms of breast cancer, and what are the symptoms of cervical cancer?
Okay.
Let's start with breast cancer.
Sometimes breast cancer can be asymptomatic, no symptom. The patient does not know that is not feeling anything, especially the patient that is not well lectured on breast self-examination and going for a routine clinical check, and also have this phobia of going to hospital. So in that case, you may not notice that there's anything that's happening there. So no symptom, no breast lump, no change in everything, but it's there.
So how can we know the symptoms of cervical cancer?
No, I'm not finished about the breast.
Oh, okay.
So it can be asymptomatic. Then it can now have a case whereby you can feel the lump. There's a lump, a palpable lump in the breast. Or you can feel that the breast is moving, the nipples are moving inwards. Okay, you can feel the breast changing, in the skin of the breast changing, looking like the back of orange. We call it peau d'orange. Or sometimes you may feel a swelling in the armpit. You may feel the breast, but there's nothing you can feel in the breast, but you have a swelling in the armpit. What we call the axillary lymph node enlargement. Then sometimes you may have a case whereby there will be itching, excessive itching of the breast, like something like eczema in the breast. Then sometimes there may be a bloody discharge from the breast. And occasionally, suddenly, a patient may just have difficulty in walking or pain at the back. In that case, the cancer has spread to the bones of the back. So, that may be part of the presentation.
Okay.
But most often, for early cases, you may not be able to detect anything.
Okay, we'll be going on a short break. When we come back, we'll be talking about cervical cancer. We've been discussing cancer and women, and we'll be going on a short break right now. When we come back, we'll be throwing more light on treatment and prevention of cancer. Stay tuned, we'll be right back.
We are a nation blessed with people of diverse cultures, religions, languages, and opinions. It is ironic that we are now being ripped apart by our greatest strength, our diversity. We have allowed intolerance, insensitivity, bigotry, and nepotism to blind our vision of the greatness we can achieve working together as one. We may not have the same culture, nor religion, nor language, but we all belong to the same nation by the divine will of God. We did not choose to be Nigerians. Nigeria chose us. This nation is our divine heritage, and if we open our eyes, we would realize that what divides us pales in comparison to what unites us. And by the comparison and conciliation of our differences, we will grow until our differences disappear. Our unity cannot be willed by mere declarations, nor do we get unity by ignoring the questions that beg for answers. We must celebrate our diversity and debate our differences without fracturing our unity. Our strength is not in our numbers, but in our unity, because even the weak become strong when united. Nigeria unite. This message is brought to you by Abuja Broadcasting Corporation, owners and operators of ASO Radio 93.5 FM Abuja, ASO Television Star Times Channel 127, Free TV Channel 507, and UHF Channel 38.
Welcome back. If you're just joining us, this is Feminine Scope, and we've been discussing cancer in women, trying to create cancer awareness. And we still have our doctor with us. You're welcome, sir.
Well, thank you.
Before we went on a short break, we were discussing the symptoms of cancer. You talked to us about breast cancer. Now, let's know the symptoms of cervical cancer.
Okay. Like I said about breast before, cervical cancer can be asymptomatic. That means that you don't have any symptom. So you just detected by just on routine examination. Patient have just visited the hospital. They say, okay, let's do pap smear, and they now found out that he has a cervical cancer or cervical cancer in evolution. What we call dysplasia. Cervical cancer or severe dysplasia. The cervical cancer in evolution is called dysplasia. So, but most often, for a frank cervical cancer, it may present with vaginal bleeding. Suddenly, patient who has mostly postmenopausal patient, that a woman who have stopped her menses, suddenly started bleeding. Or a patient who is premenopausal, then started bleeding, that not related to her menses. And we normally call it irregular bleeding. Or it may come as a foul vaginal discharge. The patient starts discharging some fluid from the vagina that is foul smelling or bloody. It mixed and is bloody. They may have waist pain, severe waist pain. So the person will start having waist pain that's coming off and on, cannot really. Then sometimes they may just have a problem with sudden feeling of difficulty in going to toilet, especially for advanced case. In that case, the cancer have extended to the back of the to the rectum, which is a part of the large intestine. Then sometimes you may have a case whereby it may affect the kidney, in which the patient has having a problem of not able to pass urine, so and there's urine retention or difficulty in producing urine. So at that point, the disease is advanced. So such presentation is common, but in most cases, it is this bleeding and foul vaginal discharge that is common among patients who are presenting with cervical cancer. And one of the things that we have done that is very making it less deadly than breast cancer is that it can be we can detect it early through just simple test, what we call pap smear. Nowadays we have a DNA test, HPV DNA testing, in which we can do some tests with to detect if there's a human papillomavirus antigen, which is a causative agent of cervical cancer, to know whether it's in the system. And from there we can go ahead, do pap smear. From there we can do biopsy, we'll go there and do confirmatory test. So it's now a disease that for women who normally go on routine health check, doctors normally include that. Apart from breast screening, they normally include pap smear. They will ask you, have you done pap smear before? You say no. They will ask you to do that. So as long as a woman is able to do it at least once in 2 years, because it takes about so many years before the cervical cancer develop. It goes through a process which we call dysplasia. So, and those dysplasia may take up to 15 to 20 years to develop. So it means that a patient who have gone on a routine health check and we detect this, we can easily take care of that without any problem. And for those who are at younger age, who have not received, because it's a vaccine-preventable disease, so who are able to receive vaccines, we will see that the chances of them developing cervical cancer becomes very, very, very rare or almost impossible.
But has there been any case of someone who has taken the vaccine still having cervical cancer?
For now, most often it's not common, especially for those who are pre-pubertal female who have completed the vaccine. It's very, because apart from that, giving her protection immunity, it only gives what we call herd immunity to those around her. Especially
really?
Yes, it gives herd immunity, especially any male that's her partner, it gives immunity to extend immunity to the male, because she will not be able to transmit the disease to the male, and the male will not be able to transmit to another person. So within the locality where such people have received vaccine, it's not likely to spread. And it's a disease that once you start vaccinating, at a point you start noticing a marked reduction in the occurrence of the disease.
Okay.
Yes.
Talking about cancer, how has government been involved in helping to create awareness of cancer?
Well, government have through their agencies like Ministry of Information, like something like this TV and radio jingles, able to call some experts to talk about the cancer. And that time, they have equally help NGOs, non-governmental organizations, to leverage on their platform to talk about cancers, and equally help them to go into rural areas to do carry out screening program. So, but still much need to be done in terms of proper treatment of patients and creating more awareness, because some of this is urban show, and the more we go down to the rural areas, the more the likelihood of having better outcome and likelihood of having reduction in the cancer cases.
How can palliative care be given to the patients? Because you mentioned it earlier. How, of course, we know someone who is already diagnosed of cancer and no cure.
Okay.
How can they be taken care of?
In that case, we have what we call the palliative care team, which is multidisciplinary in nature as well. It comprises the doctors and the nurses and the pharmacists and the rest of them. And for advanced countries, we have a place where we call hospice. But for us, it's not readily available, except for some few NGOs that are running hospices. For palliative care, what we do is that we try as much as possible to manage the case and give the patient the best quality of care. And the reason is that you cannot, on your own, commit what we call merciful killing. So what you do is that whatever the patient presents with, you try as much as possible to alleviate that. If she's presenting with a low blood level, you try as much as possible to transfuse or give drugs that will help to build up the blood level. If the patient is presenting with pain, you have to treat the pain. If the patient is presenting with the intestinal obstruction, you have to relieve the obstruction. So everything is geared in terms of improving the quality of life of the patient. But at the back of the mind of the physicians or the caregivers is that the case is not curable. And we have a case whereby those who we place on palliative care have survived for quite a long time, not minding the outcome of the disease. The reason is because of the quality of palliative care have already improved in terms of some of the drugs, some of the equipment that are using in terms of the managing the patient disease. So palliative care is no longer what it used to be before in the past. So it is now a situation whereby we give a patient care until the patient passes on. So it's no longer a case whereby a patient will be in agonizing pain until the patient passes on. So I think for now it is better managed than before.
How expensive is cancer treatment in Nigeria?
It's quite expensive, especially for those who are paying out of pocket. But patients have, of recent, benefited from government input, what we call Cancer Health Fund. And
like at a subsidized rate?
No, Cancer Health Fund is whereby the government is paying for indigent patients, those who cannot afford cancer treatment. It's a scheme just recently launched, and there are some centers that was chosen as a pilot study. What the government did, that the government funded some hospitals to enable the patient get some fund from that money and use it to treat their cases. So in that case, we have our multidisciplinary cancer group that will assess the patient. Then after the assessment, we have equally the social welfare that equally assess whether the patient is indigent or not. The aim is actually for indigent patients. It's not for everybody. So once our social welfare have assessed the patient and actually found out that the patient is actually indigent, then we will go ahead to enroll the patient into the Cancer Health Fund. And once we enroll the patient into Cancer Health Fund, all the treatment the patient is going to receive is going to be at the subsidized rate, and the patient is not going to pay out of pocket anymore.
How accessible are these funds?
It's accessible. Right now it's ongoing, and patients are becoming and benefiting. And you can
because some of these patients might not even know that there's something like this that is available for them.
Now we are discussing about it, they will be aware. Because anybody that is listening to our program will know that there's cancer health fund. But specifically, I should emphasize that it's meant for indigent patients. And you can't be riding a Lexus Jeep and come and declare yourself indigent, because the social welfare will actually find out. And once they find out that you are not indigent, you will be screened out of the program.
Okay. But as this is going on, what advice would you give government? Do you think they are doing enough?
Government is trying, but we must ask like Oliver Twist that more should be done. In terms of some of the cancer centers, some of their machines are not working, so we need to act fast and activate some of the machines. Then at the same time, we need to look at our workforce, because some of our workforce, most of doctors are not available, and because the doctors are not readily available, you find that the patient comes to the hospital to see doctor becomes very, very challenging. So waiting time becomes longer. Then
because we don't have enough manpower.
Yes, waiting time becomes longer. Then at the same time, we may have 1 or 2 issues of machine breakdown, so there should be need for immediate repair of such machines and have more in those centers. Then create more opportunities for centers that don't have functional machines, therapy machines, to have the machines working. So when government do those things, then I don't think we'll have much problem.
So what advice will you give to women?
What I will ask them to do is that they should take their health seriously, and more like coming to hospital to do routine health check. And they should not see health check as a death sentence, because even some of us do take our machine for maintenance. So especially those who have cars, you go and change your oil, go and look at the brake pads. So at the same time, you should take yourself to hospital for routine medical examination. And with that, you're able to do necessary screening. And even if cancer is found out, they should know that there's not a death sentence, that for now, most of the cancers are curable because it is detected early.
Thank you so much, Dr. Chinedu Aruah.
Thank you.
For taking out time to come to talk to us and talk to the women too about cancer awareness.
Thank you.
It's such a pleasure.
It's my pleasure meeting you. Thank you.
My guest for today has been Dr. Chinedu Aruah, the former head of Department of Radiation and Clinical Oncology, National Hospital, a visiting consultant radiation and clinical oncologist, Federal Medical Center, Jabi. He is also a senior lecturer, University of Abuja, College of Medicine, member of International Cancer Expert Corps, ICEC, and he's the Chief Executive Officer and founder, Pathfinder Healthcare Foundation, an NGO based in Abuja. Finally, when cancer is detected at the very early stage, treatment is more effective and survival rate is very high. Only 50% of cancers are still detected at an advanced stage. Improved earlier detection of cancer could substantially increase survival rates. Go for your annual check, live a healthy lifestyle, and keep lines of communication open. To create awareness, the theme for this year is We Rise. We rise to ensure every woman has access to the screenings she needs and the support she deserves. Talking confidently about breast or cervical health is very important. Step in and support awareness. Are you ready to rise? That's the much we can take on the program. Until next week, Bye-bye.